My name is Suzanne Lentzsch. I'm professor of medicine at Columbia University in New York, and I'm heading the Multiple Myeloma and Amyloidosis program at Columbia University. Today, I would like to talk about a study that was presented by Dr. Harrison. It's an update on AMG 701. This is a first-in-human clinical trial that was testing a BCMA antibody. It's an anti-BCMA CD3 antibody. And the patient population was a heavily pre-treated relapsed refractory patient population. 85 patients were included in this phase 1 clinical trials in 9 dose levels. Altogether, the study was very well tolerated. Grade 3 CRS was reversible and lasted in duration 2 days. 50% of the grade 3 CRS was driven by transient increase of the transaminases. And there were encouraging activity with responses that lasted up to 26 days. So the overall response rate of all dose levels was 36, but I think it's not fair really to include the dose levels that were very low and levels in which we do not expect response rate. So in the most recent evaluable cohort, we saw an 83% overall response rate, which was very encouraging. We also saw MRD negative patients. Altogether 6 patients tested MRD negative, which I think is remarkable in that heavily pre-treated patient population. So there was an avalanche of bispecific BCMA CD3 antibodies, and I think everybody felt a little bit overwhelmed. So altogether we had 6 bispecific antibodies presented at ASH. AMG 701, which is, I would say, the daughter of AMG 420. Then there was a Celgene antibody, Pfizer, Regeneron, Janssen, and also AbbVie. How do we compare those different bispecific antibodies? Let me start by saying I think it's very early to really judge any antibody with having a higher efficacy over the other. All of those antibodies presented were very early in phase 1. But what I want to point out that 2 antibodies, the Pfizer antibody, also Janssen antibody, were given subcutaneous. That's, I would say, a big advantage. The studies were relatively early, except the AMG 708 that included 85 patients and the Janssen antibody that included 84 patients. All other studies were much immature with around 20 or 30 patients. I think we can compare those studies in terms of prior median treatments. All of the studies had around 5 to 7 median prior lines of treatment. And in terms of response, I would say at the latest dose level, it's around 80, 60, 70%. We see that in all BCMA antibodies, but again, it's very early to really say what is the final overall response rate. I want to point out that all the patients were triple class, not all patients, but most of the patients were triple class refractory in the majority of those bispecific antibodies. And in terms of adverse events, there were around 60% adverse events, and we see that in most of the bispecific antibodies. I think the Regeneron antibody had a slightly better profile with only around 38% adverse events, but no grade 3 for adverse events. Altogether, I think we have a very competitive fields in terms of bispecific antibodies. Again, most of them IV, 2 are subcutaneously, encouraging response rates, especially in the latest on the last treatment dose levels in all of these drugs, with over 60% here, AMG 83%, but far too early to really give a final verdict. What is the best antibody? I think at the end, safety and efficacy will decide, and hopefully ASH next year or in 22 will give us more information on the bispecific antibodies and the role in relapsed refractory multiple myeloma.